Metzeler from Munich on a fascinating title, The Root of Evil, Pre-Leukemic Clones That Survive Chemotherapy Are Linked to a Higher Risk of Leukemia Recurrence. Please, Klaus.
Good morning. Thanks for giving me the opportunity to present our data. The presentation in the plenary session will actually be given by my postdoc, Maya Rotenberg-Turley, and I'm happy to talk here about our data on pre-leukemic clones that survive chemotherapy and that are linked to a higher risk of recurrence in acute myeloid leukemia. Acute myeloid leukemia is an aggressive blood cancer which primarily affects older patients. And from previous studies, we know today that AML can originate from a clone of pre-leukemic stem cells. These pre-leukemic cells still look normal under the microscope, but they already carry some somatic mutations that are later found in the full-blown leukemia. So when AML is treated with chemotherapy and the patient is in a remission, we know that a pre-leukemic clone can sometimes persist and can be detected with molecular methods. So the question that we were asking in our study is, does the persistence of a pre-leukemic clone after chemotherapy affect treatment outcomes and patient survival? To do this, we studied 107 patients who were treated on a German multi-center clinical trial by the AMLCG cooperative group. And we performed mutation analysis of 68 genes known to be mutated in leukemias. We started by studying samples obtained at the time of AML diagnosis, and we identified leukemia driver mutations. And then we went to study samples obtained during remission and looked if we can re-identify any of those mutations in the remission sample, indicating persisting mutations and potentially a persisting pre-leukemic clone. Our results, we indeed found persisting mutations in 36% of our patients. You can see here in this graph that these mutations were not randomly distributed, but they affected a very distinct set of genes. The gray bars show you all these mutations that were present in the diagnosis sample but lost in the remission sample, and the bars indicate their frequency in our patient cohort. And the orange bars show you those mutations that persisted in the relapse samples. So you see that mutation persistence was particularly common in DNMT3A, TET2, ASXL1, and SRSF2. And those are precisely those mutations that are known to occur in these pre-leukemic clones. Mutation persistence after chemotherapy was way more common in older patients. And importantly, patients with persisting mutations had a significantly higher risk of AML recurrence, as shown in the red curve in this slide. And importantly, this higher relapse risk persisted even in a multivariate analysis where we adjusted for patient age, cytogenetics, and other risk factors. So the summary is persistence of pre-leukemic mutations is quite common in AML patients who are disease-free after induction chemotherapy. This phenomenon is more frequent in older patients, and it's linked to a higher risk of disease recurrence. It is well known that older AML patients have a poor prognosis, but the reasons for that aren't fully understood yet. So the hypothesis that would come from our data is that frequent persistence of pre-leukemic clones may be one potential explanation for the higher relapse risk that we observe in older patients. With that, I'm happy to answer your questions, and I don't want to finish without thanking the EHA, because this work was actually funded by an EHA research fellowship. So I want to link to the talk of Dr. Green and say thank you to EHA.
Thank you. A question there.
Hi, Neil Osterwell with Oncology Report, Hematology News. So if I could ask perhaps the panel or someone, how do you target? Is it possible to target some of these escaped clones?
I think you should address the question to the presenter in the first place.
Okay. You're shoving, yeah.
I guess the challenge, I mean, we know that many older patients who do not have leukemia also have clonal hematopoiesis. The incidence of having a clone with a somatic mutation in healthy adults aged 70 is on the order of 10%. So the challenge will be to identify those patients who will actually relapse. And then, I mean, one option is in fit patients would always be an allogeneic transplant. We don't have really targeted agents at the moment where we can target these specific mutations. And I think it would be relatively hard to justify giving those patients additional chemotherapy at this point.
And could we ask you to comment, please, on the significance of the findings here? Perhaps Mr. Matter.
Well, I think it's significant, otherwise he wouldn't be here.
Yeah.
But it's a good point to see what the clinical consequences might be. And I think you exactly pointed out that we don't have any targeted drugs so far to really pinpoint those malignant cells.
So one thing that how we plan to follow up on the study is look at the relapses in these patients and really see, we will try to track how often these really come from the pre-leukemic clone, and that then would give us further arguments to actually treat patients who have a pre-leukemic clone after their standard induction chemotherapy.
Thank you.
Perhaps I could just add, before this sort of study, patients were treated with chemotherapy, and then many went into remission, and some of them then relapsed, and we had no idea why they were relapsing. So what this is showing us for the first time is beginning to give us a clue as to the reasons why a subset will relapse. And now we know that this group exists with these pre-leukemic clones. We can begin to ask questions about, well, why is it that they relapse or don't relapse? Is it something to do with the immune system in those patients that don't relapse? And so we can start to ask the next set of questions. So I think that's the answer to your question. It's the first step in what's going to be a long journey, but a very important step, I think.
Any further questions, please? Yes. Please use the microphone.
Karl Hammer, Spectrum Oncology, Austria. Do you think that different therapies could select different clones?
Very interesting question. All these patients received high-dose cytarabine-based therapy, so we have no comparison group. So I can't answer that question.
And it's a standard chemotherapy, so all people get the same therapy, induction therapy.
Yes.
Good question.
So,
yes.
so it could be that the clones are repeated.
You have more of those good questions? Anybody else? If not, thank you very much.